So hello everyone. Today we are going to do percutaneous Hallux Valgus correction using the fourth generation minimally invasive Hallux Valgus osteotomy in a young female with a symptomatic bunion deformity. So in this we would do a transverse osteotomy of the metatarsal and then shift the capital fragment laterally using the MIS Hallux Valgus jig and then fix it with two screws. One will be an Arthrex 4 millimeter beveled screw, and the other one would be the 3.5 beveled screw. After that, we will proceed with the Akin osteotomy. So, depending upon the extent of correction that we need with an Akin osteotomy, sometimes I do only unicortical Akin and keep it unfixed, and then use my post-operative correction in the form of taping to maintain the reduction. However, in cases when the extent of correction required is significantly more, like more than 10 degrees, then I do a bicortical Akin, and in those cases I fix it with the help of a screw. So this is the Arthrex MIS birth system. So the point of using this birth system and how it is different from any other drills is that it has a high torque and low speed. So low speed means the speed can go very low, like it can go under 1000, and the maximum speed can be 15,000. So what you do is basically with the help of the speed of the system, you can actually control the amount of heat necrosis that can happen. And then there is an option of changing, as you can see that I am changing the settings in which I can change the speed by pressing on the yellow button. So we can do 3000, 6000, 8000 or 15,000. So my standard one is 6000. And then we also have this saline insufflator. So we can put the suction tubing around this area so that we can give saline whenever you are using the burr, and for that you press this green button. So whenever you switch on the irrigation can help in giving the water to the area when you are doing the burr, and so that would help in cooling. Apart from that, we also recommend that we do not use a tourniquet whenever you're doing a hallux valgus surgery, because if you are using the tourniquet, then you don't get the blood, but without tourniquet, the bleeding also helps in reducing the swelling and cooling the system and cooling the osteotomy site. The periosteal elevator, which we use to elevate the periosteum. Its fine size helps in inserting it through small pupils as well. So in this, first of all, we put this ledge onto the metatarsal neck after beyond the osteotomy. So basically just go intramedullary beyond the medial border of metatarsal, and then we insert this wire into the capital fragment. We go all the way in till we actually reach the lateral aspect of the capital fragment. This is the end of this wire would tell us where the most proximal screw is going to come. Then after that, to facilitate the medial deviation of the capital fragment, we rotate this knob so that it can get deviated. You will see it during the surgery, and once we are satisfied, then after that we insert so once we have inserted, then we use this portion of the MIS jig. This wire goes to the most proximal slot, and then we go all the way till we see the black laser mark, and then we tighten this at the level of the black laser mark. Once we've done that, then we tighten this as well so that it remains fixed now. So this is the first assembly, and then after that we insert the jig for the distalmost screw insertion. And you see this wire goes all the way. So then you can see that it goes all the way till the edge. So these are the Arthrex minimally invasive beveled FT screws. We have two sizes, one is a 4 mm and another is a 3.5 mm. As you can see, they have a 45-degree beveled, which reduces the incidence of implant irritation and hardware removal. They have a larger cannulation, so 1.6 mm K wires are used in 4 mm screws and 1.4 in the 3.5 mm screws. And how it is helpful is because these K wires are slightly larger than the K wires that we use for the 4 mm FT screws, and due to which we can insert the guide wire easily, and hence it makes the whole procedure relatively simpler. The beveled screw also makes sure that the bevel actually sits completely on the metatarsal bone and hence reduces the incidence of the implant impingement. Now, if you look at the screws, the 4 mm screws come in the sizes from 46 to 58, and this is the standard size that we use for the proximal screw. The 4 mm FT screw normally used to come in only sizes up to 48 or 50, and it was difficult to have a longer screw. For 3.5 we have 32 to 46 mm screws, which is what we use for distal screw when we are inserting two screws. So these are the cuts for the surgery. So this proximal cut is for the osteotomy, through which we insert the jig and shift the capital fragment. This cut on the proximal side is basically for inserting the two bevel screws. So we have two cuts normally. In this case we have made one long cut. We can use anything like monocryl or ethylone for the skin closure.